My name is Menon and I'm a clinical nephrologist in Brisbane. And over the next 10 minutes, I'll be presenting to you some work I've been doing with Australian Health Administrative Datasets. Hospital admission datasets contain valuable information, including administrative, demographic, and clinical data. Important process of care measures such as length of stay, readmission rates, and critical care utilisation are relatively easily extractable from these datasets. They also contain valuable information about diagnosis codes as per the International Classification of Diseases. But this is where the problem lies, because for clinicians and researchers, making that distinction between pre-existing and new conditions is critical when modelling for important patient outcomes. As such, we have the condition onset flag variable, which most datasets have now generated, which identify new onset conditions as well as conditions that are present on admission. But this variable is only available after July 2008, and therefore predating this, the data could potentially be wasted. So the primary aim of this work was to derive an algorithm to try and identify new onset and pre-existing conditions accurately when compared to using the cough, thereby enriching existing datasets and potentially allowing data predating the cough variable introduction to be used for longitudinal cohort investigations in evaluating trends of hospital-acquired complications. The secondary aim of this work was to try and evaluate the consistency of pre-existing conditions identified using the cough variable being carried forward to subsequent admissions as one would expect. We used data from July 2008 to December 2015, and this project was part of a larger data linkage project between the Australian and New Zealand Dialysis and Transplant Registry, also referred to as ANZ data, and hospital admission datasets from New South Wales, South Australia, and Tasmania. This was linked with the assistance of Cheryl, SANT DataLink, and TDLU, and the outcomes were defined by the Australian version of the 10th edition of the ICD codes. The pre-existing conditions which we evaluated were diabetes, hypertension, and kidney failure, and the new onset conditions included myocardial infarction, pulmonary embolism, and pneumonia. So when we combined all datasets, we were left with over 12,000 patients with just under 3 million hospital separations. We excluded separations with missing dates, and we also excluded hospital admissions with less than 3 days, because often recording of comorbidities in day-only dialysis and day procedure admissions are often not comprehensive. This left us with just over 11,000 patients and over 69,000 hospital separations for analysis. In order to derive the algorithm, we used various look-back periods. So when it came to pre-existing conditions, we identified a pre-existing condition if the condition was present in the index admission as well as the previous admission. Look-back period 2 examined to see if the condition was present in the index admission as well as the 2 previous admission. And look-back period 3 evaluated if the condition was present in the index admission as well as the 3 previous admission. When it came to new onset conditions, we sought to see if the condition was present in the index admission but not the previous admission in look-back period 1. Similarly, if the condition was present in the index admission but not the previous 2 admission. And look-back period 3 was if the condition was present in the index admission but not the previous 3 admissions. When it came to the secondary aim, we sought to see if the condition was present in the index admission and was identified as a pre-existing condition using the cough variable and was carried forward to the subsequent admission in look forward 1, and similarly if the condition was identified as pre-existing using the cough variable in the index admission and carried to any of the subsequent 3 admissions. The statistical analysis was fairly simple, and we sought to see the percentage of conditions identified using the look-back period that matched with the cough variable, and we used the kappa statistic to give us a objective measure of the agreement between the two methods. So, when moving on to the results, we can see that when we examine the pre-existing conditions, what we found was that the percentage of match between the look-back periods and the cough variable, which is considered the reference standard, was highest in look-back period 1, and that sort of fell away with the longer look-back period. The Kappa statistics suggested that the agreement was moderate to strong in look-back period 1, and that it became weaker with the longer look-back period. Now, when we examine new-onset conditions, what we found was that there was a substantially higher percentage of match when you use the various look-back periods compared to the cough variable, but certainly on an absolute level, much higher in look-back period 1 than the other two. And when we moved on to the agreement, it was almost perfect in look-back period 1 and look-back period 2. And these findings suggest that look-back period 1 is potentially a suitable alternative way of assessing pre-existing and new onset condition. Now, in the secondary aim, what we sought to identify was that if pre-existing conditions identified by the cough were actually being carried forward to subsequent admissions. And what you can see, if you looked in Look Forward 1, that not all conditions identified as pre-existing were actually carried forward to the subsequent admission. But when you look at Look Forward 3, that a much higher percentage of conditions were subsequently coded. And what this suggests is that the low percentage of conditions in Look Forward 1 in part might explain why pre-existing conditions or comorbidities are underreported in research using administrative datasets. And these findings suggest that evaluation of a single coded admission has a substantial likelihood of missing chronic pre-existing conditions, and that when available, we should try and concatenate multiple consecutive admissions to ensure a comprehensive and reliable ascertainment of pre-existing conditions. Of course, this study has multiple limitations. Firstly, this coding of administrative datasets are done by clinical coders and not clinicians. We were not able to review the medical charts to verify the findings due to sheer numbers. And this study was done on patients on kidney replacement therapy, i.e. dialysis or a kidney transplant, and therefore may not be generalizable to other population groups. So in summary, this pragmatic algorithm that we've described provides a very reliable and robust approach to identifying both pre-existing and new onset conditions in health datasets that predate the availability of the cough variable, therefore enriching existing datasets, minimizing data waste, and improving patient-orientated research. The findings of this study also highlight the value of concatenating longitudinal patient data to improve reliability of coding of pre-existing condition, rather than using coding information from the index admission alone. Thank you for listening, and I'd also like to acknowledge my primary supervisor, Dr. Magid Fahim, as well as my co-supervisors, Professor Carmel Hawley, Professor David Johnson, Miss Elaine Pascoe, as well as the Royal Australasian College of Physicians for their financial support.